Next slide, please. Yes.
Good
Thank you,
afternoon,
Dr. Ghosh and
everybody.
team. I think it's very nice to have segmental approach to start with. That is the basis of any congenital and structural heart disease program analysis.
Light off.
And rightly, there should be a very checklist segmental approach where all the segments, what we want to analyze should be written and everything should be documented parallelly so that we should not miss something. So Dr. Ishita is kind enough and she is showing and going to demonstrate all the segments one by one, assuming this is a normal heart. We are assuming. And all the segments you will show. So I think Ishita, yeah,
So-
that can be bigger.
So first of all, we will start with the...
One second. May I request the screen of echo to be bigger and this to be smaller because then it will be... Thank you. Yeah, and the slide can go there. Thank you.
So to start, for any approach to a congenital heart disease, you have to be very methodical and you can't miss a step, because to cut short the time, if you miss any step, you are going to miss a lot. So starting from the first of all, you have to do a subcostal view with the probe direction to the left shoulder, and you will put it and to look for the two structures which you can see is pulsating. Now I will put the PW in one word towards the left side, and you can see it's an pulsatile flow which assumes it is to be an aorta which is lying to the left side of the spine. Now to further confirm it, you can just rotate it 90 degree, and now tracing it, if you just move and look with a left side tilt, you can see well the aorta with its branches, and that further confirms that the aorta is to the left side. While you put it towards the right side, you tilt it slightly right, then you will get to see a structure which is moving and it is non-pulsatile. And now if you keep on tracing that structure, it is draining into one atrium, which is this one.
So frequently you can see the hepatic veins and IVC coming
Now,
very close by and draining. Yes, she's
Yes.
showing it. Yes, please.
so this is draining, so IVC is draining to some chamber, and which is now, the question is what chamber it is. It is some sort of atrium, which is, it is in 99% of the cases IVC drains into the right atrium. So drainage of IVC into a atrium is the right atrium. So other points which now from the atrium proper, then comes the two atrium which we have to. So this is the situs which we have identified with the liver on the right side and the stomach bubble on the left side. So this is a situs solitus. Now putting this probe, we tilted and we get the apex on the left side. So this is a levocardia.
Dr. Amitav Chakraborty, please
Levocardia.
join us on the stage.
So
Now
the apex is on the left.
left side.
Yes.
So it is a levocardia. Now another very important thing, we will look for the loop a little later. After I identify now the two atriums are there, this is the physiological position in which we must all do the echoes. So after we have identified it, now we will just invert it. When we invert it, now we can see the two atriums. So the cursor which is to the left side, this is our left, and this is the right side. V is the left side.
I'm showing it. I'm showing it from here. Yes.
So we have identified this to be a right atrium in which IVC was draining the upper atrium, and if we tilt it little more, then we can see the SVC flow also.
So SVC coming from above, you can appreciate, yes.
So this is a red flow which is coming towards the probe, and this is an SVC flow. Now the other which is atrium, another which is there, to it we can see the flow patterns of the this is the venous drainage. Left atrium, in which we can see the three veins, the upper, usually the right upper and lower. I will freeze it, and this one. So if you can show with the.
Yes, I am showing it. Yeah. From subcostal, we can see the right upper, from the apical four-chamber view, if we are seeing, then we can appreciate only right lower in that plane.
Yes.
So the three veins, what we see in the four-chamber view, they are right lower, left upper and lower. So C is showing from the subcostal modified view. Yes. So what we were discussing, how to identify left atrium. Left atrium we identify
With
by
the-
the drainage of the pulmonary veins
Not only the pulmonary
and
veins,
the left atrial appendage.
appendages.
mainly. Yeah.
Now after identifying the atriums, it's mainly another thing which comes in mind is the fossa ovalis, from which we can identify the atriums.
So one important thing, fossa ovalis, we should always recognize where is the flap. The flap of the fossa ovalis points towards left, and in the fetal echo also, when we don't have that much of liberty, we identify LA and RA by the fossa ovalis direction, and it proves that yes, it is on the leftward side. So it is left atrium. How we identify in the fetal heart? So the same basic principle, pulmonary vein, fossa ovalis, the flap on which side, and LA appendage. From the right atrium, it is again drainage of the what she was telling, SVC, IVC, and appendage. Then if we can see other things. But these are the important points very quickly to tell, yes, this is right and this is left. This will form the base of the diagnosis of which situs it is. Because in congenital heart, we see IVC going to the left or right, is this atrium, that atrium. So based on these only, we will be deciding. Atrial situs by and large goes with the visceral situs by and large. So identification which atrium is which side and how it is connected will form the whole of the segmentals checklist. So if point 1 goes wrong, everything will go wrong. So it is very important to identify which atrium, which side. We can see morphologic right atrium to the left. In that case, it can be inversus or ambiguous, either way. Yes, please continue.
So from after that, we will come to the AV valves. So to identify the valves, AV valves always follows the ventricles. So to identify the AV valves, first is the tricuspid valve. How to identify? It is the offsetting, it is slightly towards the apical region. Another thing is the presence of AV valve. Look carefully. The mitral valve, it doesn't has any septal attachment, while the tricuspid has a septal attachment. So septal attachment of AV valve is more in favor of a tricuspid. Another thing is that, so the right-sided ventricle is the right, that is the RV. Another things which are prominent in case of RV is the moderator band which is present, and the tricuspid valve is apical to the left-sided AV valve.
I think two things need to be very, very stressed upon here. She is telling all the points. These points are better seen quickly from the apical four-chamber view.
This is the apical 4.
Apical, we can appreciate this offsetting and the attachments better. From the subcostal, we have a very, very nice thing. If she can demonstrate, we can see all three leaflets of the tricuspid valve in the subcostal short axis view. So this is trileaflet, this is bileaflet. So mitral and tricuspid differentiation can be well from the subcostal view. We cannot see from the other view that much well.
This one.
Yes, so if you can show the short axis, this is you are showing in modified view with the more long, yeah. In the cursor down, if you can cursor down, yeah. And no, rightward use. Yes, hold on, little bit rotate, you can show. Yeah, little bit more, go to the sweep more. Yeah. Yes, so you are seeing 1, 2, 3, all the three lip, yes. Acha, thik ache. So if you can fast track, yes.
Yes.
So we have a big archive to show. So we can appreciate all three valves from the subcostal view. And this is the eustachian valve she's doing. Very nice demonstration of eustachian valve. So you keep on sweeping. I think fourth chamber you can go and show. I think we need to move on. Yes.
Yes. Now after the AV valves and the ventricles, now is the outflow tracts, which we need to see. From the RV, this is the RV outflow tract. It is very important to look for the outflow tract and the valve which is attached to it.
I think
So
from
this is
the apical you start and then it will be.
And another from the LV, it is the LV outflow tract, in which the sweep you can see. The fourth chamber view. Apical, this is the apical fourth chamber view. And if you tilt is more anteriorly, you can well see the great artery which is coming out and which has the coronaries attached to it. If you can.
So she's showing the coronary. So we can see all sorts of vascular attachments. So anything coming out from left-sided heart may or may not be aorta. So she's just trying to show origin of the coronary artery is one of the very, very sure shot point by and large that it is aorta. Yes. Then more sweep. So it is all
So
sweep
it is
and
more
tilts.
sweep. If we sweep more anteriorly, then we get to see the pulmonary.
Another nice thing she is showing is the crossing. So the crossing of the
This is
great
the
artery is essential to demonstrate for a normally NRGA, normally related great artery. She has just beautifully shown this is the outflow tract which is coming from the rightward aspect of the ventricle going more anteriorly, because the anterior and posterior need to be felt, cannot be seen. The operator is moving the probe, sweeping, so he knows this is anterior and this is posterior. That's why echocardiogram in structural heart or anything is more operator dependent, and we know what we are seeing. Yes, please.
Yes. Now.
So then go to, I think, we are just showing the structures. The functionality assessment we are just not focusing as of now. Show the
Now like the normal, from the fourth chamber also we have to see whether the chambers are dilated or not. And after that, this is the normal parasternal long axis view. It is very good to see for the left atrium, left ventricle, and along with mainly the mitral valve, any problem it is there or not.
For identification, again, if we can optimize the image, make it more bigger, adjust the gain, so visualization of the minute anatomical details will be much clearer. Quickly seeing without optimization, we may miss something. We don't know what we are looking at.
Now
Yes.
after that, if we, plaques view, if we just tilt anteriorly, then we go to the inflow view, in which we can see it better. Then go for, and this is a very important view for a child. This is the short axis view, in which we can see the pulmonaries and the branching pattern.
So she's showing center aorta. The pulmonary artery is wrapping around then dividing. This is a classic normally seen orientation of normally related great arteries.
And here we can see the coronaries also.
So this is again an important detailed imaging for coronaries in pediatrics. We do observe a lot of complex coronaries.
Now for this patient also and above, we will shift one space above and we will get to see, this is the PDA view, and this.
So this patient has basically PDA, so we
PDA.
have utilized to show the segmental anatomy. Here there is a PDA, so it's a good opportunity to demonstrate. So if you can show PDA, how it need to be shown in ductal view, which is parasternal short axis view, one space up in the first intercostal space, cursor should be pointing down. It will be exactly showing the duct with its more parallel approaches. She's putting the continuous wave Doppler. We can appreciate this continuous flow. That is a good thing, sir, because if we miss, we'll be observing, yes, it is continuously giving you buzz. Yeah.
So this Doppler flow is very important because you need to see the systolic as well as the diastolic. Because in pulmonary hypertension, it is the diastolic component which decreases first, followed by the systolic, and then the reversal.
No, but sound is not getting generated. It's silent zone. Yes. So this is the, I think sir has, I think it's a very, very good thing sir has told that we are missing a continuous murmur, not only sing, so both way, it's a continuous murmur of the duct.
Now,
Dr. Singhi,
after
please use the mic.
PDA is
Yeah.
over, then we will go for the suprasternal view to look for the arch. And now, from this suprasternal view,
Oh.
with the left side towards tilted, we can see the branching patterns. And for a left aortic arch, we have to put it on the left side only. And
If you can show, see, two important things, very, very important thing again, the suprasternal views are not the common views every time used in the adult perspective. This only gives us the understanding which way is the arch by seeing the division of the first branch and fall of the arch. These are the 2 points we need to highlight. And the second, branch pattern of the arch, coarctation, and then if we go more, the aberrant subclavians. If you can show the branching pattern of the first artery going up, if you can show in the short axis, so long axis, this is suprasternal long, and then in short, we'll see aorta round. Oh, so they don't like the neck short axis, if you can show. Go to the suprasternal and show, yeah, a little bit up. Yes, she's showing it. So it is the aorta in short axis. And this is the first branch which is going to the right. So first branch going to right, and if it is dividing, surely it is innominate, which is dividing in the right subclavian and right carotid. So it is left-sided arch. Non-division is seen in if there is an aberrant right subclavian artery, which is the fourth branch. It is rare. So then she has just shown. Sometime if the image is very good, we can appreciate that tracheal shadow, bronchial shadow, so that we can understand the rings and it fall of the arch. So there is no coarctation. She is showing all the branch. See, this is carotid, this is subclavian, and then fall. And because there is a duct, we are seeing a aliasing in that point. From the suprasternal short axis view, if we sweep inward, we can appreciate, if you can go to the 90-degree cursor facing towards the left and tilt, we'll be appreciating the pulmonary veins, and this is the, what we tell crab view. Yes, she is reaching there. Crab view, this is RPA, right pulmonary artery, and that vessel, yes. This is the innominate vein coming, joining with the RSBC, and yes, yeah. You'll have to rotate. Yes, this is the RSBC innominate vein, and then below it, this is the crab portion. Yes, she is showing it. RSBC innominate. That is next baby will show. It's the pulmonary. Yes, that is the another issue with the pediatric population. Sedation, cooperation, and that we face. So this is real-time demonstration, sir. This is real-time demonstration, the day-to-day problem what all congenital echocardiographers are facing. So lot of sedation, chocolate, and whatsoever we can offer to them.
Dr. Singhi, we have a lot of cases.
Thank you. Second case we can move. Thank you, sir. Thank you for reminding. The VHD case can be brought. Thank you.
next.
See, the segmental itself is a 1 hour discussion.
Aradhya,
I must tell. So trying
Aradhya Mundu.
to make it in 10
Aradhya.
minutes is even, a regular echo is also difficult. So how we can demonstrate? It's difficult, but it's just to give an overall idea how it should be done. One nice ad by sir. This is because this sound of murmur quickly getting transmitted to everybody. So she will try to show the next bigger child if we can get. It will be easy. live demonstration of case, whatever it comes.
पिंक वाले को बुला लो ना,
Live
वो तो
demonstration.
बड़ा है.
Wherever we go, we can stop. There is no end of learning, sir. I completely agree. I know. So whatever we have learned, and that we should know completely rather than little bit of everything.
Let us have the babies ready because changeover time is too much.
আরেকটা বাচ্চা কি পাশে এসে থাকতে পারে? I'll tell the name.
This is Aradhya. উঠা উঠা উঠা.
আলিয়া খাতুন পাশে থাকবে। আলিয়াকে পাঠিয়ে দেবেন। এটা উঠান আগে। আলিয়া সুলতানা।
কিছু হবে না নিজে.
So now she is going in a fast tracking mode. If you can go to the anatomical mode anatomical mode, we are more anatomical than the general population. It helps to understand the segmental anatomy much better. Continuously trying to think which segment after that. So segmental anatomy, when we discuss 3-tier system, one is atrial tear, one is ventricular tear, one is great vessel tear. So we need to connect one by one, and that is better if we do physiological imaging. Yes.
So this is a four-chamber view in which we can see and well appreciate that the left-sided atrium and the ventricles are much dilated with respect to the other. So to look for it, now we are, chup, abo, ऐसा
So
नहीं करते.
first thing, before putting the transducer, we should know a little bit short history and clinical examination, including saturation. Otherwise, we'll miss. This I am just adding, may not be in agenda, but we should.
Okay.
Everybody, whoever is touching a child or congenital heart, we should know it will be immensely helpful. So
This is
she
a
is
child.
showing dilatation of the left heart, and we can appreciate there is a flow coming from the just in the region of aortic valve leaflet where it is getting connected to the tricuspid. So there is some flow which is systolic in nature. If we had ECG, we could have shown. And it is showing a high gradient. If you can demonstrate that, yes. So you can take, yes. So you sweep. So when we come to the VHD, we need to see the location. This is the communication between below two chambers. It is looking restrictive. She has just done the continuous wave Doppler and showed high gradient. Location of the VHD, if we are coming where it is there, perimembranous, muscular, outlet or inlet, number, and associated thing, very commonly tricuspid valve and aortic valve, mainly non-coronary cusp, which comes in relation. Sometimes right coronary cusp can be coming in contact and it can cause AR.
This restrictive pattern is well demonstrated. If you put your palm over the chest, there is a thrill which is of around grade 3 to grade 4.
Again, she is
And
supplementing that picture that we should see the patient before putting the probe. This thrill means there is systolic, some event is happening, and it cannot be a large VHD if we are knowing the VHD. Restrictive VHD, thrill. Large VHD, no thrill. Simple thing.
So
Yes, she is showing now.
Now this is another view in which we further see that this VSD is in relation with the tricuspid valve. It is very near to it. So this is the
Anteroseptal commissure of the tricuspid valve and non-coronary cusp, they are in relation to the VHD that we can appreciate here in the short axis view. You can appreciate this is the septal tricuspid valve, the anteroseptal commissure, and usually this is the non-coronary cusp. If she goes a little bit more, the location of the
yes.
Show where is the VHD location. In the short axis, yes. So here, yes, here we are seeing the right coronary cusp there. I'm telling location of the perimembranous VHD is in relation to non-coronary cusp.
Non-coronary.
Location.
Yes.
So this is the non-coronary, this is right and left, and sir is right. This is coming from the zone of non-coronary, right coronary junction.
Others are okay. And things which are especially see for the VSD is whether there is presence of AR or not, as it is very close to the cusps, because it helps in the further management. And another thing, if the VSD was very near to this this pulmonary valve, instead of the tricuspid valve relation, it would have been a subpulmonic VSD.
Just stop for some time, if you can show that same thing. See, if we see this is a clock, so 9 to 11, this is the location of the perimembranous. 11 to 1 is the outflow region. In between, there is some terminology called intraconal. So basically, if it is 11 o'clock to 1 o'clock location, more close to the pulmonary valve, subpulmonic VSD. This is the best location to understand. In the parasternal long axis view, if we see a VSD, if aortic valve and immediately below we are seeing in the regular parasternal long axis view, there is a possibility that the VSD has extended to the outflow septum.
Now from this.
So hitting of the VSD jet in the outflow can lead to some muscle, can cause Gasul effect. That one thing. Two associated things, duct, additional VSD and coact. These three things we should keep in mind whenever we are seeing a VSD. Notoriously, additional VSDs are getting missed if there is a large VSD. Presence of a large VSD, the small VSD will not shunt. So we'll have to go to the subcostal view, reduce our gain, and look for additional VSD, especially if it is apical. Very difficult. Swiss cheese apical VSDs are frequently associated with large VSDs. Small duct frequently getting missed. Yes. No, we'll show one and we'll. Yes. So I think this you have shown that the next this one you just show. Please. Yes. So the more important is to have an idea how the congenital imaging is different. Getting an history, saturation, clinical examination, and then putting the probe, sedating the child. That is a big 30-minute discussion how we need to restrain the child. So thankfully the baby is sleeping and possibly will be nice to us. Thank you. Oh, yo. So yeah, ECG lead, yeah, we correctly, congenital one, we should do ECG lead because which part of the cardiac cycle the events are happening, we may miss. In VSD, putting the leads are again important because we frequently observe this bidirectionality of the shunt. So whether which part of the cardiac cycle it is left to right or right to left, that we cannot ascertain just by looking at single glance. ECG is extremely important in that. Oh, so nice of you, dear. Thank you. So now she is showing quickly something, and very beautifully she is demonstrating in the subcostal short axis view, there is a big communication, and so there is a large VSD. There is a large VSD and the restriction of the outflow. We can appreciate the conal septum, which is little anteriorly deviated. The VSD is right to left. Whether she can demonstrate an outflow, we have still not seen a definite outflow. Yeah, if you go to the, yes, and subcostal, I think she may not like subcostal. Yeah. So we are unable to see a definite outflow. We have appreciated a large VSD which is shunting right to left. So if you can jump and come to the, So again, targeted these type of situations, you are forced to give some opinion. You will have to quickly see the important things. The timing adjustment is little tricky, sir. You don't know. So pedicloryl is our lifeline. If pedicloryl goes out of market, there is a crash of the pediatric cardiology community of the city or the state. I am telling you. So we love pedicloryl. All brands we know. See, Sleep, Kiji, pedicloryl, etc., etc. So all alternative goes off same time. Yes. So
From the short axis view,
we are unable to see a outflow. Nicely she is showing something very nicely. You can appreciate in the short axis this big aorta, large VHD, and there is no outflow. So this is a large subaortic conoventricular ventricular defect, right to left predominantly, and no outflow. So it is pulmonary atresia with large VHD, which comes under top pulmonary atresia category. The saturation could have helped us to know beginning.
it was 70.
So 70% saturating, and there we are expecting, because she is showing a flow, the branch pulmonary artery she is showing small. If you can show from the arch view, the peculiarity of the tetralogy pulmonary atresia, we frequently have PDA from the undersurface of the arch or more proximal nature having tortuous course. So yes, she is showing. Oh, yo. So this is that undersurface of the arch, and the duct, the flow we are seeing, this blue flow is coming. Yes. So from the undersurface of the arch, it is coming and it is filling the branch pulmonary artery. Demonstrating is extremely important, whether it is duct dependent or there are additional collateral. Frequently, if we can analyze, see, it's good. All collaterals we may not be able to pick up, may require CT pulmonary angiogram to demonstrate in the small babies. Nowadays, stenting of the duct. So important, we can do a palliation till we get some time to put a conduit repair. So assessment of the duct, its anatomy, insertion, and branch pulmonary artery sizes, extremely important. This I am discussing in context of tetralogy of fallow pulmonary atresia. Regular tetralogy of fallow, yes, again, and lot of things we need to see, the additional VHD, level of obstruction, what nature of obstruction, coronary crossing RVOT, aortic valve dilated or not, and whether aortic regurgitation is present or not.
Mention in the reports the LPA size, RPA size, descending aorta at the diaphragm level, and the PV annulus, because each and every report which comes with the TOF might not the patient next time allowed to do. Each and every report with TOF must have all these 3 points at least, and the presence of any residual VSD, whether present or not. Because in the operative, just post-operative patient, the VSD which has been closed, but due to the presence of the other residual VSD, the post-operative period might be more dangerous. So it is very important to mention all these things, and the PDM, yes, the pulp, yes, the coronary artery.
Thank you, Ishita and Anil. Can we switch over to the next case? We are actually running short of time.
So we have shown the three important what we thought.
Next session, a few patients are left, so
So patients we have kept for 3-hour session. We can keep on.
Okay, we'll
Yes,
see
yes, please, sir.
Let them not feel disheartened. We'll see the patients later.
Yes. Yes, sir. Yeah. Angulation, yes, sometimes if you cannot align properly, your gradient will not be correct. We go in that case approximation and how is the laminarity of the flow, whether it is restrictive or not, and other parameters. Every time we may not be able to align the jet very well. So you go by the LA-LV dilatation, we do Z-scoring, and overall, how much is the hemodynamic and growth effect of that defect? I am discussing about the moderate shunt. If it is very large, then there will be laminar flow. So laminar flow means it's large VHD, whatever is the gradient, it's large. Maybe less than 20 what we tell. Restrictive, the child will be doing well, LV will not be that much dilated. So moderate one, there may be difficulty. That is approximation. So by trying from different views, we try to align the best possible. But the decision is taken holistic, not only based on single gradient number. How much is the LV dilatation, how much is the impact of the child on the growth and etc. Then overall decision is taken moderate VHD. So whatever you are getting maximum, sometimes it overestimates. You are getting a gradient of 120, but baby's pressure is only 90. So how it is possible? So that is the
Dr. Ishita.
overestimation calculation. So what I do, more than 80. So I am correct, more than 80, but I have not put an absurd number of 123. I check BP also. So we sometimes can miss a hypertensive patient. It may be.
Thank
So
you,
we should
Anil.
check that one also. Thank you. I think, yes, thank you for allowing us just to give a bird's eye view of a congenital heart disease. 17 years in the field and I am learning daily.
Yeah, thank
5
you,
minutes.
Ishita,
Thank you,
and,
thank you.
Dr. Anil, for beautifully demonstrating all the cases. And actually, he started from the normal one, and thereafter towards some of the abnormals. Thank you, Ishita and Anil. Thank you very much.
Thank you,
Let's close the session and go to the next one.